if it's something that that's who you see yourself as, and ER nursing is your persona, then you know what? Wear it like a freaking superhero cape.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. I hope this podcast finds you well this week. If you are listening to this in real time, my guess is you probably had a pretty busy week. I hope you and yours are doing okay and staying safe. Please be careful out there. Please be careful taking care of those patients. On behalf of my guests and me, I want to thank you for doing what you do, taking care of the communities that you care for. And again, please be careful. I'm thinking about you. I'll definitely keep you guys in my thoughts and prayers. And we'll be doing everything we can to advocate for emergency nursing and supporting in any way we can. If you're listening to this in real time, then tonight, Monday night, we are going to be doing a virtual happy hour, an ER nurse virtual happy hour that I'm going to be hosting with my friend Sarah Wells. We are going to get everybody together on a Zoom call, a Zoom meeting, and give you guys a chance to say hello to your friends from around the world. So if you're listening to this, we'd love to have you join. Go to my social media page, go to Sarah Wells' social media page, and you will find information about this. If you're not listening to this in real time, and I know not everybody does, we're going to try to make this a regular thing, depending on how this first one goes. And hopefully you'll be having this as a regular thing while we get through this pandemic nonsense. Again, my thoughts are with you. We'll be doing what we can from our little corner of the world. You take care of you and yours. I'm taking care of mine. And let's do the best we can to take care of those patients. I wish you well. I hope you're doing okay. And please reach out if there's anything I can do. You can send me an email. You can reach out to me on social media, or you can call the voicemail line, 832-299-5132. One more time, that's 832-299-5132. You can reach me on the voicemail line. Leave me a voice message. I check that fairly frequently. Now save that number, because we're going to be doing some special things with the voicemail here in the next couple weeks. Let's get on to today's show. Today on the show, I have a 30-plus year ER nurse. She's a certified emergency nurse, critical care nurse, trauma nurse, and peds nurse. She's got all those certifications. She is a nurse, an educator, a nurse thought leader. She's had the opportunity to teach all over the world with her company Paragon Education, and now she's here for you on the podcast. I hope you enjoyed what was one of my favorite interviews to do in a really long time with my friend, Cheryl Randolph. Go ahead and introduce yourself to the audience. Tell us who you are and what you do.
Hey folks, this is Cheryl Randolph. I am an emergency nurse. I wear a lot of hats in my life, as a lot of you do, but first and foremost, I see myself as an ER nurse. I currently work at San Francisco General Hospital. We're a level 1 alcohol receiving center. No, wait, that's wrong. Level 1 trauma center in the heart of San Francisco. We're an urban county hospital, so you can imagine what we see and what we do. I work there as a staff nurse, and I've been there for, good Lord, 21 years, which is astonishing, because when I was hired, I told the nursing manager that I'm known for, short assignments, and I'll probably not be there more than a year or so. And here it is, 21 years later, I'm still there. Who knew?
How funny.
But I find the chaos and the rapid pace of a teaching hospital to be quite stimulating. And I'm at that age now that those young whippersnappers listen to me, and when I yell at them, they pay attention. So it's with age comes power. It's wonderful.
There's a lot of truth to that. In the middle of the city, and it's just straight. It goes straight up.
Yeah, that's us. That's us. It's an old hospital that was actually built in like the 1880s, And we still have buildings there that are these old brick buildings that literally I think you can see and feel the ghosts moving about.
Maybe I'm thinking of a different place, because the place that I'm thinking of, where we went, was like in the middle of the city, and it looked like a skyscraper.
Gosh, maybe you're somewhere else. We are, I wouldn't say we're in the midst of the city. We are in the city proper, the southern edge of the city.
Okay.
And it's in an area called the Mission. So, in fact, the old name for San Francisco General was the Mission Hospital. Some people still call it that.
Interesting.
But we had a new building built about, 2-3 years ago now, that is a nice big skyscraper that is 7 floors high, I believe. And, of course, they could have made it 14 and twice as big, and it still wouldn't be serving our needs. So they kind of underestimated what we need. Isn't that a shock?
Every hospital I've ever gone to, they build them up. They build them up, and the hospital outgrows them before they even move in. So that's certainly been what I've seen. I must be thinking of a different place, because the place I'm thinking of, it looked like it was just another building in the middle of the city. So
there's a brand new place called California Pacific Medical Center, CPMC. They just opened a couple months ago. And they are literally in the heart of the city with this big, beautiful skyscraper for people who have private insurance.
Gotcha.
We're county, Kev.
Yeah, we're county. I understand. I grew up in a facility like that where, we were the place that if you didn't have any money, it's where you were going to come, and whether you had all the money in the world or no money at all, we treated you exactly the same.
That's us. That's county.
Yep. And that's
and I can never go back. I've kind of got the county attitude and the county way of dealing with both my professional colleagues and my patients that I don't know that I would ever survive in a private community hospital. I think I'd get called on the carpet the first day for attitude.
One of the big stark contrasts I had in my life was I worked for a county hospital that was, again, it was the, I say it was a county hospital. It was a university hospital. It was an academic medical center, but we were still kind of known as, we had been called University of New Mexico Hospital for the longest time, and people still called us Bernalillo County Hospital because that's what they used to be, and it still really was what it was. But I went from there to the VA, and the VA was a very different contrast in that, you're dealing with all old vets and everything that comes with that, the good or the bad, to a private nonprofit hospital. It was a faith-based hospital, which was a first for me. But it was they were nonprofit in name only. They were very much a for-profit organization. And it was the contrast between those three organizations was just huge. So
yeah, totally.
It was crazy. So how long?
But it's great. Oh, I was going to say it's great fun at any one time. I've got residents, medical students, nursing students, paramedic students, fellows, attendings. Everyone. It's happy chaos.
Yeah, I love that environment. I'm much more at home in that environment than I am in the county hospital where, where at night there's like one doc in the whole hospital. So yeah, I'm much more comfortable in that environment. So how long have you been a nurse?
Gosh, I don't know. Someone out there is going to be able to do the math, but the years work out to 31. I think as of this year. It started out. It's actually my second, third, fourth choice of what to be when I grew up.
Really?
Originally, I went to school and I was going to be a doctor. I was pre-med. I was biology, chemistry, did all that stuff. And about halfway through that, I just lost the faith. I didn't think I was smart enough, and changed. And I said, well, if I can't be a doctor, I'll be a lawyer. So then I decided to I got a degree in political science, which with a degree in political science and a $5 bill, you can get a latte. Okay, that's about it.
Gotcha.
Just absolutely worthless. So after graduating with that piece of paper, I looked around and said, well, gosh, maybe I could be a nurse since I can't be a doctor. so I had some prerequisites. I lined up, got into nursing school about a year and a half after that. And the very first day of nursing school, oh, good Lord, I went to nursing school in Southern California. And it was at Golden West College, Huntington Beach, California, a 2-year program. And it's really a misnomer to call these 2-year programs because you had 2 years of prerequisites to get into the 2-year program.
Exactly.
But nonetheless, I'm here at day one of this 2-year program, and I look around the room, and hell, I was 23 years old or so, and I already had 1 degree. I'd been around a little bit, wasn't such a green kid, and they said, well, everyone stand up and say, who you are and why you want to be a nurse. And so I looked around at these people, and I thought, God, I'm going to be hanging out with these people for the next couple of years. And people are getting up, and they're like, oh, I want to be a nurse because I want to end the suffering in the world. And I want to be a nurse because I love children. And I got up, and I said, I'm Cheryl Randolph, and I want to be a nurse because I look great in white. The whole place just stared at me. No one laughed, no one moved, and I could see the instructors in the back row just looking at each other like, holy God, we got to watch this one. And sure enough, I wound up in the principal's office more often than not. But, something to be said about the way we, at least in the past, educated our nurses, and just such almost a militaristic point of view and a very top-heavy, authoritarian way. I don't know. Did you find that when you were going through nursing school? Was like that?
Oh yeah, and it probably still is to this day. I mean, I think and shout out to my nursing instructors because I know at least one of them listens to the podcast. So I'll can't see.
Not you. We're not talking about you.
We're not talking about you. And the reality was she was amazing. We had a couple nursing instructors who were absolutely amazing, and they were more progressive and kind of had a clue. But we had a lot that were just not current, they weren't super current in their practice, and their thought was that nursing school was something to be survived.
Exactly. Exactly. And I used to call shenanigans more often than not, and I just got trounced for it. It was like, well, no, don't you see how this is nonsensical, X, Y, and Z? And they were like, you're being insubordinate. I'm like, I'm just calling a spade a spade. I'm just trying to make sure we're all perceiving reality as it is. Well, and it was hard.
Yeah. The kind of funny thing for me is when I was going to nursing school, I was going to nursing school at a community college where I worked full time.
Oh, good Lord.
So can you imagine? So I would be in class with these nursing instructors, and then I would go sit in my office as an EMS instructor and literally be right next door to them.
Oh my gosh.
You can imagine how uncomfortable that made everybody.
Wow.
But the bad news was I was in that community college. I was in that building probably 12 hours a day, 6 days a week for a year and a half.
Yeah. It was brutal.
Yeah.
And I know people are out there doing the same thing now. I was 23. Let's see, how'd it go? I was 25. I was 25 when I went through and graduated 2 years after that, and it was 27. And I was one of many who was going to school. It was 4 days a week, and doing clinicals in that, and also working.
Yeah.
To pay the rent, and literally just a 24/7 existence. And I know there's others out there doing it right now. In fact, my niece is getting into a program. She's starting in January, and bless her heart, she's doing the same thing. She's finishing some prereqs. She's got 2 young kids, and she's going to be trying to juggle family, a job, and nursing school.
Yeah, it's tough.
It's not easy. So, those new grads, bless their heart, we sometimes forget what they've gone through to get there.
Yeah. No, I agree 100%. And they work hard. They work hard for it. And as did I, as did you.
Yeah.
So at what point in your nursing career did you know you went into the right profession?
Kind of not so early on. I went through a how do you say a planned clinical preceptorship in critical care nursing. I was very, very lucky, fresh out of school. Literally, I ended school like on a Friday and started this job like 2 weeks later.
Wow.
And it was a local hospital. It was a precepted combination didactic and precepted program. Three or four of my classmates from nursing school were in there with me. We were all of a like age, all brand new nurses. And we had this wonderful 5-day-a-week program that literally we had classes in the morning, preceptorship in the afternoon, and after that we had a precepted program. When you finally, were working the job, doing a 12-hour shift, you were precepted and you had someone with you there, 24/7. And it was, in retrospect, it was fabulous, fantastic. I mean, I literally think somewhere here in my mess of an office, I think I still have my notes, from the classes that I took.
Yeah.
And it was just a wonderful, wonderful entree into critical care nursing. And what they did was they then put we new people into a telemetry unit. So it was a little bit of a step up from a med-surg unit. But we did telemetry nursing and had like all the fresh open hearts and the real, real sick medical people. And then after that, after a year or two, most of us graduated into working into ICU. And sorry, long story here. So after working in ICU for about, six or 8 years, this one day, my manager came up to me and she said, "Oh my God, Cheryl, they're absolutely drowning over in ER." And I thought, oh, good Lord, those ER people, the ones that bring me these patients, what do they need? She says, well, Cheryl, could you go over and help them out? And I thought, well, of course, I am, after all, a CCRN. Why, I'm sure I could help those little simple ER people. Well, bottom line is I went over to ER and basically I got my ass handed to me. I didn't know what the hell I was doing. It was just such a different world. I still remember my very first patient was someone who had a bee sting, and I just stood staring at them, and I looked at another nurse, and I said, what do I do? What's a bee sting? I mean, what implication does that have for me?
Yeah.
And they were just looking at me like, you are just the biggest idiot. And I was like, oh, yeah, I can put a central line in someone. I can tell you what their Swan-Ganz pressures are, but, I didn't know how to, the simplest thing that, how to take care of these patients. So ultimately, I kept coming back, even though I was the stupidest one there and just didn't know anything. And as being the greenest nurse, the least ER experienced nurse, you know where they put me?
Triage.
Right. Right. And in retrospect,
but you know
I look
why?
back at that. You know what? Because it was getting me out of their hair.
Exactly. So that used to be where you put all the nurses you didn't like. If you didn't like the nurse, you didn't want to work with the nurse. If the nurse is maybe a little slow, put them up in triage. They'll be fine.
Exactly. Oh my God! I look back and think about the patient standing there, and in fact, I remember this one in vivid detail. Because, people would come to the little window. That was in the days where you had like the waiting room with the window, and you kind of stood there and talked to everyone, and you said, well, how many times have you had gonorrhea? Oh, okay. And you just, everyone knew everything. So this one day I remember distinctly, these people are standing in line, and about second or third in line is this man standing there with a small child, and the kid is like 2 years old, little boy, and he just looks horribly punky. He's got circles under his eyes. He's just looking horrible, sick, and he's drooling. A 2-year-old who is drooling. Are you with me so far?
I'm with you so far. I know where this is going.
Oh, dear God. And any rational, sane, intelligent, prudent emergency nurse would look at that, grab that kid, go back and think, what, epiglottitis? Because I always want to rule out what will kill you on my shift. That's my foremost conclusion.
That's a good point.
So I'm going in exact opposite of that rationale, though, because I'm green and I'm stupid and I don't know any better. So I'm taking the first person first, the second person second, and this poor guy again is standing there holding his young child. And thank God my charge nurse came into my little area at that time and kind of looked over my shoulder, saw this kid, went out and got him and took care of him. But you know what? In retrospect, I wonder, were lives lost? It was certainly not the way to have your greenest, least experienced nurse eyeballing the room for who's looking, sick or sickest.
Yeah.
You know, and it's not just that across the room assessment that we do with, with children. Hell, I do it at Costco. I'm looking across the lines at Costco, and I'm telling the guy next to me, hey, I think you should go in and get your thyroid checked. Your eyes look a little bulgy, and there's a little lump in your throat.
That's
funny. But in those days, I didn't know any better. I was doing it like you were at the DMV, first, second, third.
Yeah. No, I certainly remember those days of the window, and you stand there, you tell them what you're here, and then we'd either get you back right away or not. And I could see where an inexperienced nurse would be like, well, we're going to take these guys one at a time and just work our way down.
Yeah, exactly.
That's crazy.
Through it all, I love the serendipity of ER. I love not knowing what's going to come in next. It's going to be a pregnant person. It's going to be an old person. It's going to be a kid. It's going to be an infectious disease. It's going to be a chronic thing. It's going to be something we don't know what the hell it is, and we're going to have to Sherlock Holmes this. You know, I just love the variety that we get, and the onus that it puts on me too to be that jack of all trades and to know a little bit about everything. Instead of being just so specialized. You know, I have friends that, I'm a cardiac nurse. It's like, well, there's other systems. Okay.
Yeah.
You know, there is some other stuff you need to know. I like having that wide knowledge that we have. It makes me feel more powerful.
Yeah. When we had one of the best nurses I ever worked with was a nurse named JD, and he was a ICU nurse and then became a flight nurse, and he was a phenomenal nurse. But he absolutely hated the ED. Like, he would come down to the ED and he was just anxious the whole time he was there. And he was good. He knew how to adapt, but he was an ICU nurse, by golly. And he was like, I can't deal with the chaos of the emergency department. And now he's a CRNA. And again, he's like, oh, the chaos of the emergency department. No, thank you. But there's just different specialties for different people.
Yeah. Well, it's always like those of us who have been ICU and do ER, you get bored of one, you get burnt out on another, and you kind of bounce back and forth over the years. There's a real difference in perception of an ER nurse and an ICU nurse. It's like all those memes that you see out there that, kind of poke fun at it. But truly, an ICU nurse, they know, well, gosh, on his left forefinger, he has a slight abrasion, and, his mother's father's son had, cystic fibrosis, and in his history, he's had he got a hepatitis shot, 3 years ago. ER nurses are like, he's breathing. He's got a heartbeat. He has a pulse.
Yeah.
We are like, just down to the common denominator. So it's always a rude awakening for an ICU nurse to come to us and see that our expectations are so oftentimes a little bit lower.
Yep, exactly. Tell me about a patient who changed the way you practice.
Changed the way I practice. Okay, here I got a good one. Years ago, and this was actually something that happened in ICU, but it's something I've always remembered. Years ago, I was in intensive care, and here it is, end of shift, and as we do, giving bedside report. In fact, I still find that that's helpful, and to be right at the bedside, introduce the patient, know that the handoff is going on, show the other nurse, particular patient things or drugs or, whatever else you have at the bedside. But years ago, I'm doing bedside report, change of shift in the intensive care unit, and the patient was a post-open heart patient. So I'm giving report, I bring the other nurse in. I say, hey, hey, Mr. Smith, hey, this is, Nurse Jones. She's coming on. She's going to take care of you. Yeah, hey, you did really good today. Yeah, you're doing great. Here, I'm going to go outside, and I'm going to talk to her for a little while. He's like, oh, okay. So I go back outside, and, you're going through the notes and orders and things and giving a report. And I'm all done, so I turn back and I look at this guy, and he is in bed and he's sobbing. He's absolutely crying hysterically. And so I go back in the room. I'm like, Mr. Smith, what the heck's going on? Why, what's going on? He's like, I heard what you told that other nurse. And I'm thinking, oh, Jesus God, I'm known for making comments that are unseemly. I'm thinking, oh, geez, what the hell did I say now? I said, what did I say? What did I say? Why is he goes, you told that other nurse that I'm going to die and I'm not doing very well and it's all over for me. And I'm like, what? I said, no, you're doing great. You're going to go transfer tomorrow to telemetry. You're doing fantastic. You're doing really good. He goes, I heard what you said. You called me a vegetable. I said, what? He goes, you called me a cabbage. And I thought, oh, good Lord. I did. I called him a cabbage because that's what he was. Cabbage, right? Cardiac arterial bypass graft, cabbage, open heart bypass, whatever, open heart surgery. Yeah, cabbage. That's what we call them. And I had to calm this guy down. I literally had to get a piece of paper and write down cabbage and explain to him what that meant, and that, no, I wasn't telling the other nurse that he was a vegetable and he was going to die and it was bad. No, it didn't really mean that. And it's one story that I've remembered over the years because it always reminds me that even though we use these acronyms and these terms of art and these, I don't know, what do you call them, nicknames or whatever for things so flippantly and so easily and so understandably for us, that, these patients, they're not in our world. They don't know what these things mean. And so many medical terms can be taken misinterpreted. They can be misunderstood. They can be taken, as an insult. So it's just one story that over the years it's always reminded me to be wary of using medical terminology with people who aren't hip to it, to make sure that they understand things, to clarify it for them, because it is their first rodeo, even though it's not for us.
Yep, absolutely. What becomes just every other day to us is like life-changing day for our patients.
Totally. And it's nurses who are the ones who are able to perceive that, I think, on a daily basis. I love my doctors. I think they do a fantastic job. But it's the nurses more often than not that I see really getting down to the human layer and taking that person literally by the hand and saying, hey, it's going to be okay. Here's what's going on. Let me explain to you what's happening. We had a horrible, horrible trauma a couple weeks ago, and it was one of my nurses who, as this person's being wheeled in and, there's a medic that's doing something, someone else is putting a tourniquet on, there's blood everywhere, there's a mess, there's lines, there's total chaos. It was the nurse who reached down and got like an inch from this guy's face and said, hey, my name is Sabrina. We're going to take care of you. Everything's going to be okay. We're going to take care of you. Don't worry. While everyone else was doing all the technical things that, ultimately would hopefully save that person.
Yeah.
But you could just see how frightened they were and how foreign everything was around them, and that they needed just that little human touch.
Absolutely. That goes a really long way.
Mm-hmm.
That goes a really long way. So tell me about the first medication error you made. Do you remember it?
Oh, good God. Yes, I do. And do you know what the medication error was?
What's that?
It was that I was giving it an hour late.
Okay.
I was giving it an hour late, and Kev, here I got to tell you. So I'm here, brand new nurse. I've been on the floor for all of 6 months. I was still, in probation or whatever they call it, and I somehow realized I've not given this medication, and I found one of my friends, one of my cohorts, who was in the same boat with me, and I grabbed her and said, "Oh my God, I forgot this medication. I haven't given it. It was due at 10 o'clock, and here it is at 11, and I haven't given it." And she just looked at me like I was the biggest idiot in the world, and she's like, "Cheryl, it really doesn't matter. It's kind of, it's nice if those things, line up, but you're giving Prilosec an hour late. It's okay. It doesn't really matter." over the years, I'm sure there's been a lot of other errors that I've made. As far as I know, nothing has killed anyone, but I certainly remember that it has to be into perspective of when these things are given, how they're given, other medications that are perhaps being given with them, that nursing has a huge understanding of sometimes what's more appropriate than does pharmacy.
Absolutely. Yeah, it's one of those where you're like, on the good bad scale, probably not a big deal.
Mm-hmm.
You're like, it's going to be okay, honest.
Mm-hmm. Mm-hmm. Although I will tell you, a very, very good friend of mine, a protege, in fact, years ago. This is, gosh, I've been doing this 31 years. This is probably 25 years ago that this happened. Back in the old days, I don't know if you remember this. Back in the old days, before pharmacy was having all the drugs made and things, we used to, in intensive care especially, very often you would give patients a IV push dose of Lasix, and you would follow it by making a potassium piggyback, a 10K potassium piggyback, and hanging that as an IV drip. Do you remember those days?
I don't remember that. No.
Really? Okay. So this was our standard. This is back in the 80s into the 90s. So you would, for your cardiac patients, obviously, you'd be giving them a dose of Lasix, get rid of that extra water, but at the same time recognizing that was going to reduce their potassium. So it was kind of a standard. It was like 40 of Lasix and a 10K K rider, 10 milliequivalent K rider to follow.
Gotcha.
Well, in the old days, again, pharmacy did not prepare these. Nursing did that. And you had these two vials. You had a 40 vial of Lasix. You had the vial of potassium, which, if you remember ever seeing those, it was like the same size and shape and sometimes even lid color as the normal saline vial and the sterile water vial. They all looked
really?
exactly the same. They looked exactly the same. Just different color lids. And the fear was always that, good God, you would mix up your syringes and give potassium push and give instead a Lasix rider. Does that make sense? So
okay.
in a perfect world, what you were supposed to do is you had a syringe you drew up of Lasix, you gave it to the patient, IV push. You had a syringe of potassium, you then put it into a 100 cc piggyback, you mixed it up, you put it up, and it was an IV drip that they got afterwards. That's what you were supposed to do.
Okay.
But the worst case scenario was when you switched syringes. And what you wound up doing was giving your patient potassium push and then a Lasix rider. And since they're clear medications, you wouldn't know the difference until something happened. And the sad, horrible story, and again, this is someone I know that this happened to. This is not made up. This very bright, young, beautiful, intelligent nurse. She switched the syringes somehow. Somehow it got mislabeled or just confused. She gave potassium push. She did the other medication, went into the piggyback. Sure enough, about 2-3 minutes later, the patient coded. They resuscitated the patient, and they got him back. Afterwards, everyone's kind of brainstorming, hey, what happened? I don't know. He's a post-open heart. They were going over history, trying to figure out what happened. And in a quiet moment alone, she realized what she had done. She went to the attending physician and told him what had happened and told her charge nurse what had happened. And for that honesty and for that self-incrimination, she was fired. She was fired, and the family was told that the nurse had made a huge mistake and almost killed the patient. And it was a horrible thing. It was a horrible thing. And I always think of her sad experience when I think about nurses making errors and finding errors within a system and coming forth and saying, hey, here's a risk, or here I did this, or here this was a near miss, and I think we need to attend to this, that that whistleblower or that person who is even incriminating themselves isn't always protected.
Yeah.
And I think it really colors our willingness to point out mistakes or to point out our own errors.
Wow. Yeah. That's, the whole just culture thing really makes a big difference, because if people are punished for reporting mistakes, then they're just not going to report them.
Exactly.
They're just,
Exactly.
it's going to be swept under the rug and never brought up. And I remember the first time I made a med error, the first time I made a med error as a nurse, like I pushed the med, we were doing a sedation, I pushed the med and I got my syringes mixed up. And I immediately told the doctor, and the doctor's like, it's fine. It's okay. Let's just kind of watch him. Let's get a little bolus started. And the guy was fine. The guy was over sedated like a mofo, but he was fine. And I remember going, I said, the doctor goes, so what do we do about this? And I said, I'm going to go to the director right now and tell him. So he writes me up. He's like, what do you mean? I go, I made a mistake. I got to tell the director was like, Kevin, you made a mistake, but everything's okay. The patient's fine. He's like, we can do a PSN. We can do a patient safety, briefing on it. He's like, everything's okay. And he's like, you got to be more careful. What are you doing? And I was an experienced nurse by then. And I was like,
yeah.
I know. I don't know what I was thinking.
And too, I think there's almost a dumbing down that's occurred to try to rectify mistakes that could be made. For example, at my hospital, everyone else these days, gone are the days where you got medications, looked at a paper order, got the medications, checked it against the order, and gave it to the patient. Yeah. Now it's in the computer. You're scanning them. You're scanning the med. You're getting whatever the computer spits out at you. You go to the drug ATM and you punch in the patient's name, and whatever they have in their profile is what you can get or what you can't get. And you go from there. And I find myself sometimes just going down the list of, okay, they have those drugs. Okay, get those drugs, as opposed to looking at the order, checking it against the medication. Do you know what I'm saying? I think the way that they're compartmentalizing the medications has almost made us less likely to check it against the order, because you just assume everything is fine. You assume that whatever's on their profile is what they're getting. You assume that they're supposed to get whatever it is you're pulling out, because it says it's 10 o'clock and those are the 10 o'clock drugs.
Yeah.
And I think it's really dumbed us down. I mean, I have found myself more than once having to go back into the drug ATM to, oh, wait, that was 2 vials I needed of that. Oh, wait, that was, 1 pill I needed of that, not 2, or, having to change it up because I'm just blindly taking what they're offering as opposed to checking the order.
Yeah. I was getting report just recently. And when we were giving report, and she said, this young lady was there with a migraine, and she was getting their typical migraine cocktail, which was 3 meds kind of all at the same time, a bolus, a saline bolus, and then maintenance fluids to end it. And the nurse goes, all 3 meds are in, bolus is done, IV is running. The IV fluids were running, the maintenance fluids were running as a carrier, and then she was going to get the bolus. So she goes, so I just started the bolus, and I look up and I go, are you, and the pump's running a bolus, and I go, did you mean to bolus the normal saline, D5 normal saline with 5 with 10, was it 10 a K, 5 a K, whatever it is, the D5 normal saline with potassium? She's like, oh my gosh, no, that's not what I meant to be bolusing.
Yeah.
And we stopped it, and it ran for a little while, but it was fine. It was like one of those, like, okay, that, and it's a simple, easy mistake to make, that if you don't have that second eyes.
Yeah. And luckily, 10 mgs of potassium, isn't going to hurt anyone. But God, years ago, talked about drug mistakes. Yeah, y'all remember the days when you used to push Dilantin?
I think that was before my time. I don't
my
think
God.
I've ever.
Okay. Before you say "okay, boomer" to me, you just watch yourself, Mister. Okay, because what I'm telling you here is some history, for gosh sakes.
No judgment. I'm paying attention.
Oh my God.
I'm sitting at the feet of elders, paying attention.
Okay. Oh Jesus. Okay. So here's the story. So 1,000 years ago, when I was a nurse, on the telemetry floor, this is before pharmacy would make drugs for you. You just used to have vials of things, and you would either make your own piggybacks or you would do pushes really slow. So this guy needed some Dilantin, and so I was doing a Dilantin push. Well, there's a rule with Dilantin that you only ever give it in normal saline. Do you remember that?
I don't remember that.
Now, see, because no one ever gives it anymore like that.
I'm aging myself or something. I don't know.
Okay. All right. Well, so there's a pharmacy rule that Dilantin only can be in normal saline. Well, here I am. I walk in with my syringe, my needle that I've swabbed the plastic port, and I'm sticking my needle into the port of my IV tubing, because that's nothing is lure locked in those days. And as I push this drug in, suddenly the entire IV line going into my patient turns milky white instantly. And I instantly realized, oh, wait a second, he doesn't have normal saline running in this line. This line is like D5W. So it was like, holy crap. So, I grab it instantly, shut it off, rip it out of his arm. It was a rude awakening that, oh, yeah, there are drug interactions you need to watch out for. Oops.
Yeah,
Oops.
Absolutely.
So, yeah, there's one of my drug mistakes.
Oh, gosh. That was a good answer for one question. That's awesome.
Yeah.
I love it.
When you find that nurse who hasn't made any drug mistakes, you let me know who that is, okay?
Right. So, I've asked every one of my guests, I think I've asked every one of my guests that question, and almost everyone has given me an answer. And one goes, gosh, I don't know that I've made any drug errors. And I'm like, then you just don't know about them. You've made them. You just haven't paid attention.
Seriously.
I'm like, because everybody has.
That's probably scarier. If you say, no, I've never made a mistake, it's like, no, you've not made a mistake that anyone died.
Yeah, or you haven't made a mistake that you caught. So
Exactly.
Tell me about a patient that touched your heart. A patient that you'll never forget.
Who's touched my heart? Let's see. Okay, here's someone. In fact, this was just a couple months ago. We are a trauma center, so of course we get all the traumas, MVAs, gunshot wounds, everything that's happening in the city. So this young guy, 25-year-old, no meds, no allergies, no history. He's an MVA. He's restrained, but somehow he manages to hit his head on his windshield and actually star it. So for that reason, we're going to do the full, trauma workup. So we do a head scan on him. And, I send him off over to CAT scan on his own. He's stable. He's fine. I'm not perceiving any problems. Well, CAT scan calls me up and says, hey, our doctor sees something really weird. Is your doc okay if we do a CTA on him instead? I'm like, yeah, sure. So, I yelled this back to my doctor, and he's like, yeah, CTA is fine. Well, they do a CTA, and then they call back again. They go, hey, you guys might want to come over and take a look at this scan. So we go over and look at the scan. I always love the that scan while they're still on the table, and everyone's looking at it going, holy crap.
Yeah.
Well, we look at this scan, and I will tell you that if I can read your CAT scan, you're not doing well. All right.
Amen. It's like the housekeeper and then me as far as CT reading skills. So if I can look at it and go, oh shit.
Yeah,
that's
exactly. Bad. Exactly. If I can read your scan, there's a problem. So sure enough, me and the ER doc go over there and look at this scan, and I'm like, holy crap. We look, this guy has got this huge aneurysm, just huge, to the point where radiology says, let's just leave him on the table for a minute. I'm going to call neurosurge and see if there's anything else they want us to do. So literally the guy's still sitting on the CAT scan table, and that never happens. They're usually, off the table instantly. He's still sitting around the table. Neurosurge comes down like about 5-10 minutes later, says, okay, here, get this other cut or this other view, Sure enough, we do these other tests, and everyone is just in a frenzy, So neurosurge is like, oh, holy God, this is a huge aneurysm. Oh my God, we got it. We're getting this done today. We got to fix this. So literally, I'm getting the guy off the table, taking him back to ER. Neurosurge is talking to him. Neuro's talking to him. My ER doctor is talking to him. Everyone's talking big words of aneurysm and rupture and disability and death, and they're just talking all these huge things to this guy, and he is just hyperventilating. The guy is freaking out, necessarily so, at being told all of this. Well, finally, all these people leave, and Nurse Randolph is left with line him, lab him, get him ready to go to surgery, get that blood consent signed, all those, I'm left with the paperwork and the explanations. And I look at this guy, and he's just sobbing. He's just crying little girl tears. He's just so hurt and upset and just lost. So I said to him, you know what? Here. First of all, you're fine. First of all, you're not dying. Nothing's going to happen to you. Let me explain what those doctors said. And I literally took it chapter and verse, and thank God the Google helped with a couple visual aids. But I took it chapter and verse and explained all the big words and aneurysm and the approach that they were going to use. They were going to do take him to cath lab and do it embolization. And so I clarified all the big words that they had used, and I showed him some pictures and told him what it all meant. And this poor little 25-year-old just kind of like perked up, and he's like, you mean I'm going to live? I'm going to be okay? I'm like, yeah, you're going to be absolutely fine. He's like, I thought they were going to cut my head open sideways and try to fix it. And I was like, no, they're not going to cut your head open sideways. No, it's but it was again, one more time that it just over every single day, I think I realized this, is that people don't talk our language. They don't know these big words. There is a significant health illiteracy that's out there that every single day we have to approach and we have to clarify. In my perfect world, there would be health education every single year of public school and health skills and understanding these things so that people would know what basic terminology or basic preventative care know what vaccines actually do.
Yep.
Because there's such a huge disconnect in this country of the facts versus what people are told online or what they hear or what they see a meme of, or good Lord, and there's just plain ignorance that this poor guy. And then we compound it by using big words, instead of explaining things simply and logically. And the bottom line was, finally, I had this kid, understanding, hey, yeah, it was a serious thing, but he wasn't going to die and it was going to be okay. Where 5 minutes later, or 5 minutes earlier, rather, he was, hysterical and thinking he was about to die. So yeah, it happens every day, I think.
Yeah, every day. I always wonder how being as a family member to someone who's in the hospital, I'm always there, and I kind of advocate for the patient, and I advocate for my family members when they're there. I always think to myself, these poor people that have no one to advocate for them and no one to explain what's going on. Like, how do they get by? And how they get by is by the good graces of nurses all over the world, where the nurse says, okay, now that the doctor is gone, let's talk about this.
Exactly. I mean, one of my famous lines is that, hi, I'm Cheryl and the nurse here. Let me help you out with what's going on here today. Hey, we're doing this, and the reason we're doing this is this, and then we're going to do this, and after we find out, then we'll know this result, and I just want to keep you guys informed. And 9 times out of 10, they are just, first of all, horribly grateful for that, but 9 times out of 10, they're like, oh, no one else has told us anything.
Yeah, all the time.
Because
Happens
we just assume everyone, even though it's our 84th rodeo, we assume that they know, when of course they don't. This is not how they plan to spend their day.
Absolutely. It's one of those things that it's one of the most powerful things you can remember is that, your patients, this is not every day to your patients like it is for you. So
Mm-hmm. I say that to my trauma patients all the time. I say, I know you didn't plan to spend your day here, but let me tell you what's going on.
yeah, for sure. So what's the best advice a nurse mentor ever gave you?
Get more education. Keep learning. The best cure for burnout is education. The best cure for feeling inadequate is education. There's always something more to learn. There's always another angle on something maybe you think you already know. Every day in my practice, I think there's some new facet of physiology or pharmacology or patient assessment that I learn. And like I said, I've been doing this for a while, so that's kind of significant. I don't know. Maybe I wasn't paying attention in nursing school. Something there's always something new that comes up, though.
Yep.
And I still take classes, read books, look at articles. I just got a couple of my journals the other day, and although quite frankly I don't read my journals cover to cover, what I do is I flip through, and if an article intrigues me, I rip it out, I staple it, and it goes on my bedside table, and I actually do look at it ultimately.
That's
so
cool.
there's time and place to kind of get this stuff into your head, and it helps when you're faced with the mundane ridiculousness sometimes of our job. I've got the frequent flyer drunk that I'm cleaning up for the 900th time. Kind of helps me that later that night or something I'm looking at something about some kind of physiology gem that's going to help me down the road.
Yeah.
Because certainly we do have a lot of mundane moments that you think, wow, this is what I went to school for?
Yep. I certainly have been there. So what advice would you give a brand new nurse going into the emergency department for the first time?
Oh my gosh. It gets better. I'm kind of on the fence about new grads going into the ER. I think it's really difficult to deal with really, really sick until you've seen sort of sick, on the floors or in some other area of the hospital practice.
Yeah.
I know there's nurses that have done it, and I've had colleagues in my place as well who have been fresh out of school and went through a program and have done great. But overall, the stats are kind of horrific for attrition of a brand new grad going into ER, because it's a chaotic situation. And it's a situation where very often we're making it up as we go along. We're thinking on our feet. We're changing what's been planned. And those changes and that quickness to recognize a need for a change in plan, that rationale doesn't come quickly to someone who has never done the job. And I think it's difficult for those new people. So what can we do? I don't know. We can support them. I think there needs to be preceptorships. That the new term I hear everyone using is a residency. Have you heard that term used?
Oh yeah.
Yeah. So nursing residency is a great idea, because I think there's a fair amount of time that you need someone literally by your side while you're learning the job and learning every strange new A to Z disease that's coming into your place.
Yeah, that's true. The powerful thing I think about residencies is, like you said, as a new grad nurse in the emergency department, I think you just get overwhelmed by the sheer volume and everything that you see during the day. Even if you have a brilliant preceptor, you're seeing so much during the day, you just can't process it all. And the advantage of the residency is where you have kind of somebody to process with, as you go through and kind of explain things and be like, hey, what did you see this week? Let's talk about it, and let's kind of talk our way through it. Because there's no education like that just-in-time education of, of knowing something either just after you needed it or hopefully just before. So
yeah, exactly. And so different from other specialties. If you were on labor and delivery floor, you'd be like, okay, well, this was an elderly pre-map. Okay, that was a cord prolapse. That was a funny-looking kid, whatever. I mean, you would have stuff, but it would just be within one system, within one, specialty. For us, it's like, well, here's a cardiac patient, here's a OB patient, here's a chronic disease, here's injury on top of chronic disease. So for us, I mean, it's just so multifaceted that for a new grad who, still doesn't have quite the recall and understanding and association of that book learning with what they see in the real world, for that person to try to put that together with every single new patient that's coming out is hard.
Yeah, absolutely. It's just hard to keep up. I mean, it's hard as a professional who's been around and seen some stuff.
Totally.
I mean, mind blown as a brand new nurse.
Yeah, totally.
So that's cool. The last question I always ask everybody on the show is a question called 3 Things. And it asks for 3 things that a new nurse should remember and 3 things that they could just go ahead and forget.
Well, that's 6 things, Kevin.
I know. It's three things to remember, 3 things to forget.
Okay, 3 things.
But you're right. It does add up to 6.
See, I got that math right. That math.
Okay, boomer.
Yeah, see? That's going to be your new phrase today. Okay, boomer. And you got to say it real sarcastically.
Sorry,
okay,
I didn't say it sarcastically enough. I'll work on that.
It's got a bye, Felicia. It's got that kind of tone to it, okay?
That's right.
Okay, so 3 things to remember. Number 1, you're not alone. ER is a team sport. You have always got other people there. You have always got other support, either in pharmacy, in hopefully management, in your fellow nurses. There's always someone else to turn to for discussion on a patient, a situation, a disease process, an understanding of a doctor's order, an interpretation of an order. So keep it together that it's not you on the line every single day. You've got other people that are there to support you.
Yeah.
Number 2, being an expert takes 10,000 hours. Have you ever heard that?
I have.
They say to be an expert, you should have 10,000 hours, and 1,000 hours a year is the basic. So to be an expert, you should be in the job for 10 years. Well, 10 years, it starts with a single step. So you got to recognize that, hey, here I am, a new nurse. I'm starting off. Sure enough, I'm going to make mistakes. Sure enough, I'm not going to be the nurse maybe I'm trying to hold myself up to be. I'm probably not going to be perfect. I'm going to make mistakes. And you got to recognize that with time, you're going to be better. I'm a better nurse today than I was last year. I'm a better nurse last year than I was, 5 years prior to that. Every single day in my practice, I've learned something. I've done something different. I've learned how something works that I've applied to my practice, and every day it's served me well and served my patients well. So those single steps, someday you're going to be at 10 years, you'll be at 20, you'll be at 30 years, and then you'll marvel over what you've forgotten.
Yep, absolutely.
Okay, 3rd thing to remember, try to remember why you're in the practice. Try to remember what's your rationale. And if it's something as mundane as that you look really great in scrubs, hey, awesome. If it's something that that's who you see yourself as, and ER nursing is your persona, then you know what? Wear it like a freaking superhero cape. A friend of my husband's asked me the other day. He said, "Oh, hey Cheryl, your husband told me that you're a nurse." I said, "I'm an emergency nurse. I save lives and fight disease. What do you do?" He's like, "Well, I'm an interior decorator." I'm like, yeah, like that's going to come in handy for the zombie apocalypse. And he just stared at me. And I thought, this poor sap, that's his identity and that's who he is. Hey, that's awesome. But I am so happy with my chosen personal view of who I am that I'm an ER nurse. It's how I see myself. It's how I address myself to the world. And literally, I save lives and I fight disease. That's what I do. And these are skills. These are hard skills that will serve me well in the ER centers, in the trauma room. But walking down the street, you know how it is. And you can't turn off being a nurse. It's on 24/7. I'm on vacation walking down the street, and I don't know, I've got that nurse walk. People are asking me for directions. Or I see people who trip on sidewalks, and I go over and I'm like, okay, how many fingers am I holding up? Are you okay? And they're like, speaking a foreign language to me. But I'm trying, though. I'm trying. Yep. So that's my 3. That's my 3, and I'm standing by it. So be proud, be an ER nurse, wear your freak flag.
I like it. I like it a lot.
3 things to forget. Gosh, I don't know. I've forgotten. What are 3 things that you shouldn't really worry about? Don't worry about not sitting at the cool kids table in the beginning. Make your own cool kids table. Don't worry so much about that you don't know everything, because it's taken for granted that you don't, because, you're new, and it's going to take some time for that to seep into your head. And lastly, something else to forget. Here's my famous saying. My famous saying is, high school never ends. And you know what? There's always going to be someone who's going to say something that's going to make you angry or sad. There's always going to be, a cooler kid who knows something or says something or has some angle on our profession that you don't agree with. High school never ends. It's always going to be that back talking and an environment of people being together and having, I don't know, bad talk go back and forth. So can you forget about it? Do your best. We all need to grow up. But again, high school never ends. Get over it.
Yep. No. Sometimes it does feel like high school, doesn't it?
Yeah.
So
there.
Too bad.
That's it. That's all I got.
All right. That was pretty good. You did a good job. You did a good job.
Thanks.
So anyways, well, again, thank you so much. And I'll be talking to you soon.
Okay. Thanks so much.
I appreciate your time.
Bye, honey.
Bye.
I've just learned the latest put down for those of us who maybe aren't so hip.
Oh, yeah?
The latest put down is, hey, boomer, or no, wait. Oh, shit, and here, look, I'm old and I'm even fucking it up. Oh, God damn it. It was, oh, shit, Kevin, I'm messing it up. It's something like, okay, like, baby boomers.
Yeah.
Okay, right? And it's like the retort that some millennial would say to you if you said something stupid to them. They'd be like, right, boomer.
That's funny.
It's okay, boomer. Okay, boomer.
That's funny.
Yeah, you're an idiot. Okay, boomer.
That's funny. It's kind of funny. Yeah, I'd seen some kind of article about how that was like, you're right, how that was like an insult.
Yeah.
And I didn't read the article, but I was like, oh, come on.
Yeah. And here it says, it's the millennial put down. Okay, boomer.
That's funny.